Hello everybody. Whenever you stand up here, you always feel as a bloke desperate to check your flies are pulled up before you do anything else. But I won't. I've already checked. You're okay. Okay, I'm Robert Flack. Yes, my middle name begins with A, so yes, I am Roberta Flack, just to get that out. Yes, I was born on the 22nd of June 1972. Roberta Flack was number one. My mum and dad didn't have a clue, but nevertheless, I still got Roberta Flack. Everywhere I go, people ask me if I kill things softly, etc., just to get it all out on the table. I am chief executive of an organisation called Locala, and when people pick up the phone every now and then, we go, oh, hello, Carla, but actually we're called Locala. Locala, we are a social enterprise that was born out of the NHS out of PCT in October 2011. If I talk about transforming community services and that policy, just give me some nods. Do some of you sort of know what I'm talking about? Yes, there's a few people who do. Okay. So, who are we? Well, we are an organisation that do in excess of 1 million patient contacts a year. We based mainly in Kirklees, which for those of you who don't know the finer parts of Britain, that's Dewsbury and Huddersfield. We also do quite a lot in Bradford and in Halifax and a little bit in Leeds as well. What do? We do 85% of what we do is in the patient's home. We also run some GP practices. Usual services, district nursing, school nursing, health visiting, big, broad range of community services that many of you will be aware of. So, that's us in a nutshell. £50 million-ish turnover, 1,200, 1,300 staff. However, why did we do what we did as a social enterprise? And this is where I'm going to come to in terms of this talk, because I'm very, very aware that in 15, 20 minutes you will probably have access to a glass of something cold and more refreshing than I can give you now. So what I would just want to do is tell you about a few stories about us and a bit about what we've done. So, 3 things really to talk about that I just want to just share with you. So first of all, Locala is a mutual organisation. Our organisation is owned by our employees. So we are not the classic NHS trust. I know in some foundation trusts have gone down this route a bit, but we are owned by our employees. We are registered at Companies House and owned by our employees. And that makes a very big difference. Our employees paid £1 per share in October 2011. They have absolute direct control over the appointment of the board and over how the organisation works. And that does change the psychological contract. I always try and find a nicer phrase than psychological contract, and I can't. But it makes a really big difference. We sit down in a room with the unions to have our union bits, and the biggest membership organisation sat around our table is us. That really does change things with some of the unions, I can assure you. It fundamentally changes how we operate as an organisation. And one of the really nice things, as bizarre as this sounds, is I get sworn at a lot more. I walk into rooms and actually people who own our business tell me that what's going on is not bloody well good enough, thank you very much indeed. And that is great, absolutely great, as far as I'm concerned, because that means you've got people who are acting as advocates for the patient. A statistic I always like to use, we are actually the 13th largest employee-owned business in the country, in any sector. So John Lewis are the biggest, and we're the 13th largest. I know there is a big drive around mutuals in 2 or 3 parts of the public sector, and there's certainly some other parts of the public sector that have really driven this, and we've helped some organisations do that. What I would say is it really does make a difference, and it's not always easy to put your finger on exactly why, but it really, really does make a difference, down to the levels of people actually say, this is the company that I own's money, so I'm not going to waste it on A, B or C. I want to see it work properly. So, we're employee owned. It makes a really big difference, a really big difference. Second bit is we're a bit technology obsessed. So, and I'm going to tell you a few stories around some of our technology. So we took a decision about 3 years ago now, about 3 years ago, that the classic NHS IT provision couldn't do what we wanted to do as an organisation. We wanted to be as agile and as flexible as we possibly could be. We wanted to get direct access to System 1 from the patient's home as often as we possibly could, and we wanted to use technology and information to fundamentally change our business model. And to do that, we needed a level of expertise that we were struggling to find inside the NHS at the time. So we took a decision, and out of interest, for those of you that do, we don't have to follow OJU. It's lovely. All we have to do it properly. We want to do it properly, but we don't have to do OJU, which in itself is probably worth a load. But anyway, we ended up signing a major deal with Dell and Microsoft, and critically to us, to me as the chief exec and the board, is we did that out of our own money. We did not do that out of money that the NHS had given us from Nursing Technology Fund or any of that. We did it out of our own money. The importance of doing that as an organisation was critical to us because that meant we had to make it work. We had to make it work. And in essence, that has led us to really engage our employee owners, our people, into really thinking about how we change the model. And there's a load of stories I could tell you, and I could have you here till 10 o'clock tonight telling you stories about this, but I'll try and pick a few out. So, about 6 months ago, I went out on a Monday morning with one of our community matrons, very senior nurse who works in a community setting. And we went to see Jeff, who has Parkinson's disease. Those of you who with some clinical knowledge in the room will understand that Parkinson's disease goes down in stages. So often someone can be very, very steady and then they'll drop quite quickly, and then they'll steady and they'll drop quite quickly. What happened over the weekend is Jeff had really, really deteriorated quickly over the weekend. And that had meant that Jeff and Jeff's carer had slept about 4 hours over the weekend. Jeff had wet the bed on numerous occasions. There'd been some real cases of confusion, and it had been a really, really, really dreadful time. So when me and the community matron, I was just shadowing, turned up at sort of 10 o'clock on the Monday morning, there was this sort of two exhausted people and a sort of overwhelming sense of what do we do now? Well, with our technology, we invested in Microsoft Link. Many of you probably know what Microsoft Link is, a sort of fancy Skype, basically. What we could do, what the community matron could do, was she could see immediately, well, I need a pharmacist. There's a pharmacist available that I can speak to who employed by us. I need a physio. I can see there's a physio available, employed by us. I need an OT. I can see there's an OT available, employed by us. And I could really do with the GP, actually. And this happened to be one of our GP practices. So I could see the GP was available. So this community matron then led a conference call there and then in the patient's home of 8 clinical professionals and the carer to talk through what they were going to do to help Jeff settle. And Parkinson's is often about how do you manage the drugs versus how do you manage mobility. And it's trying to work those scenarios out, to work it through. With the carer, this conference call, this video call, in which everyone could see the System 1 record, so everyone could see what Jeff was on and how that worked, a decision was made to change the drug regime. The drugs were delivered within 25 minutes. There was an agreement the physio would be in at lunchtime and the OT would go in that evening and the GP would go tomorrow morning to check that the drugs were fine. Jeff immediately settled. The carer got some carer relief to make sure that she could have a rest that afternoon. There was a complete and utter fundamental change, and that was the technology and the leadership of the clinician working together. And that was a fundamental difference about how we have used technology to change people's lives. And in essence, I'm going to tell you a few more stories in a minute about how we've really taken some of that from. In essence, that story, to me, made the investment that we'd made, the X million quid over 5 years, just worth it in one. Worth it in one. Because in essence, we'd really made a major difference to Jeff and how Jeff worked. What else have we made some stories? Well, some of it will be about efficiency. So the average school nurse is expected to go to each school in their patch's first assembly, or near as damn it, first assembly of the year. Essentially say, hello, I'm the school nurse. In Kirklees, I should know this, we've got something like 68 schools or something like that. Well, you can imagine that it's the end of the first term, not even the first half term, before a school nurse has got to every assembly as on their introductory bit. So then you've only got 2 terms left to do what it is that you need to do. Simple stuff. Okay, school nurse, we'll do a video. Let them play that video. If they want some live streaming, we'll do live streaming straight away. Immediately, that introductory process is done in a week rather than done in a term. straight efficiencies, the vast majority of schools prefer it because then they have the flexibility about how they use it in their assembly and it works in a much, much better way. Third story, and this is, I love this one at the moment. So, we've spent about the last 6 months trying to find a fancy bit of technology for our out-of-hours, I don't really like using the term out-of-hours, but let's just use it for now, so our nights and evenings teams. Most of those are district nurses, some of them are social workers, some of them are also therapists. And we've been trying for ages, and there's various things called guardmen and all sorts of stuff, all of which are pretty good, quite expensive. And then, for some strange reason, we'd not decided to go out and chat to the team about it. We decided we'd have a look for a fancy bit of technology ourselves and got the IT guys onto it. And eventually we went to them to say, we're really struggling with this, it's really expensive, we don't quite know what to do. And they went, well, what are you on about, love? I said, what do you mean? Oh, we've been using a private Facebook thing for absolutely ages. We just use our timeline on Facebook, it works a treat, it's free, and it's private. And we went, what? And then they showed us it, and it's fantastic. It's absolutely fantastic. And we went, aren't we absolute idiots to start off with? We've always had a view that actually any member of staff can go onto any website that they want, as far as we're concerned. If they're daft enough to go onto adult websites, then they shouldn't be working for us anyway. But actually, if the patient's on Facebook, then they should be on Facebook. That's where they should be. So actually, let these people use Facebook, that's fine. There's no problem with it whatsoever. Because in the end, it's all about culture, which is where I'm going to come to in the final bit of my talk, and I will make sure that I keep to time. I suppose just a couple of other bits to share with you. Today, our district nurses will have undertaken about 50 virtual consultations with people. Those consultations will either be where there is a healthcare assistant at the patient's home dressing the wound, and they are checking that that wound has been dressed okay, or the patient themselves is dressing their wound. And the district nurse is simply just checking that they've checked that and done that well themselves. That is one of those marvellous moments when the district nurse has said, patients won't like that, they won't want to do that. You go and ask the patients and they go, oh God, I'd love to do that. That's absolutely fantastic. That makes a massive difference. So we know that that works, and it's again by creating the right culture, which I come to. And I think the third bit, it's just a lovely little story I just like telling, to be honest. And this was about an old dear with dementia. She was quite well-regulated dementia. She was about 83. And it's a real level of confusion. She's a lovely old dear. And I went to see her with a district nurse as well. It turned out this old dear loved Ken Dodd. Absolutely lived for Ken Dodd. Somebody asked her, so absolutely lived for Ken Dodd. But she was a nightmare, an absolute nightmare at keeping to her regime around her dressing. And she used to get dressed and then to get it taken off and a variety of other things. What our district nurse did was go, well, I'll tell you what. When I come in tomorrow, I'll play you some Ken Dodd off YouTube if you've still got that dressing wound, that dressing on. And so went the day after the dressing was on perfectly. She got Ken Dodd for 20 minutes. Tell you what we'll do tonight. I'll play you Ken Dodd when I come in if that wound's done on. Within the next 4 or 5 days, that wound had cleared because of Ken Dodd and YouTube. And that's about fundamentally rethinking how that person had delivered care. And that stuff, as far as I was concerned, was brilliant. I'm not going to bore you with efficiency. We do know that just by putting this technology in, we're seeing about 10% more people than we were. Minimum, absolute minimum. In some cases, it's nearer 16 to 17%. As an organisation, that's meant that we have managed to cope with a load of extra demand and reduced resources, and we are an organisation that has got cash in the bank and is doing sort of okay financially in these very challenging times. But I really want to talk, finally, I suppose, about culture. So you've picked up the bit about employee ownership, you've picked up the bit about technology, and I think what we did not want to do for a minute was A, invest all that money and then go, oh, it doesn't work, there's all sorts of problems or whatever, but B, not allow people to go and try stuff. So I've talked about the fact and go onto Facebook and Twitter and whatever else you want to do, that's absolutely fine. And been on Facebook now. Anyone can go onto Facebook. For 2.5 years, we've had 2 very minor incidents. So as far as we're concerned, that works. What we really want to do is create a culture where people felt they could innovate. So we've done a few things. We've got people in who are sort of innovation gurus to try and help with people to say, go and try stuff. It doesn't matter if it doesn't work. We'll give it a whiz. It's no problem whatsoever. What we really wanted to do was enable people to go and invest and try something completely different. And again, I could tell some stories about that, and in a way, I suppose I've already told a few already. But there are a couple of things that we've done that innovation has come about, which are not necessarily technology related. So one of which is that we have changed the way that we will, occasionally you have to go into people's houses at night to turn them to make sure they don't get a pressure ulcer or whatever. Always had to have 2 people doing that with us. It was through some connections made on social media that we discovered that most of the time the firemen were actually not being called out overnight, but you had to have firemen there. So now our district nurse to turn people will go out with a fireman, which you can imagine is quite popular. But again, fundamental change of resource and rethinking how that works. You're dead right, we get lots of volunteers to do that, yeah. But again, that was about a real different sense of innovating and doing some of that in a completely different way. And I think the other really important bit about innovating has been about how we've interacted with children's services. We started this wonderful discussion, which many of you in this room will have had, I'm sure, where we sat in with a group of health visitors and said, how are we going to do this better? Shouldn't we start interacting with people through technology? And they said, no one wants to do that. They want us to go to their homes. We've got to go to their homes. That's what we've got to do. So we went out and asked 58 parents. 58 parents said, we'd much rather interact with you on video. Much rather, please. Thank you very much indeed. So that's how we do it. So we now do that through Facebook, and we now have bookable appointments on video, 5 till 8, from 5 o'clock every Friday till 8 o'clock every Monday to Friday, Saturday morning, Sunday mornings, which are very popular, which are about how people can interact. And in the end, they came up with that because they worked out that's where they were as young mums, on Facebook or in other places, and they wanted that video. So it was about creating a place and a space where they could innovate, and they could do that from home. And that fundamentally changed their working practice. So that was not them about being in a hospital until 8 o'clock. That was them being able to think about how they changed their life, their working life, and do that from home. So that was about the power of technology. Now, I could really, really, really happily talk and share a load of stories with you, but it's probably, I've got 4 minutes and 50 seconds left, and I've got a lovely one of these, which I wanted to play with for the last 50 minutes. Does anybody have any questions at all? And please, if you haven't and you're on, just go and find a beer. That's fine, I don't mind. Anybody got anything they want to ask? Go on. Well held, sir.
What's he got to do with GS1?
I'm not sure, to be honest. I just met Glenn and liked him. I suppose the short answer is I'm not sure, and I could easily talk a lot more about efficiencies. I think one of the bits is where do we think technology is going for us? And I think one of the challenges around this is actually we believe technology is going around how the patient interacts with us with technology. So we as an organisation are preparing for how we might, for instance, not just share a patient record, but give the patient record in lock, stock and barrel to a patient, and then enable them to share that with us through using things such as barcode technology, if you see what I mean, which is a fundamental change to how we do that. But we're about allowing a patient to maximise independence, to self-care, to take more control over their own care. The more we can do that, the better. If our access route to that care record is through a barcode, which we think it probably will be, then that enables us to have a system that we can use to flow and manage our business. Do you see what I mean? So in many respects, we're members of GS1. That's where we want to really start exploring. Yeah, of course, we spend money on dressings and all that sort of stuff, and that's really, really, really good stuff, and we've got a load of work to do on that. But we're really interested in how do you make barcoding enable a patient to maximise their own independence and take more control over their own care, as opposed to how do we just become more efficient.
Can I ask a follow-up? So, two sort of follow-ups from that. System 1 are not renowned for their ability to open access to their data and stuff. So if you want to do anything with it outside, that produces some interesting challenges. But also, are you talking about developing patient portal on top of it, as per what you've just said?
So certainly, the bit about System 1 I agree with. We have got major experts in System 1 in our organisation, and making sure that we've invested to get that right is critical. Getting it to a place where it's open access has been much more difficult for us, and we hope that is changing. Are we planning to look at how we build portal? Well, our response through this is we are very sort of active members of the ODI, Open Data Institute, very actively involved in trying to understand how we can work with partners such as Dell and Microsoft to enable us to create something that would sit on top that is patient-owned. At the moment, we are in the very, very early thinking of that. I suppose the early conversations have all been about apps, and yes, we've got an app, for instance, around continence, and we do some stuff around apps around continence. The thing about apps is if I'm anything to go by, I use apps for 3 or 4 weeks and then go on to another one and on to another one, so just creating apps I'm not so sure is necessarily the answer. I think it's about trying to find a much more fundamental way of changing some of that. So our response is to try and work with partners that will enable us to do that. Any further questions? Chuck it back.
Probably aren't any, because I threw it last time and killed somebody. I'll try a bit more gently this time.
Well, hell, we haven't dropped one yet.
Hi, thank you for that. I guess most people have a smartphone. Most households will have some sort of PC. Do you tend to encourage people to use their own equipment?
Yep.
And is that okay? Or have you had to invest quite a lot in IT out into the community?
So the honest answer is it's a mixed bag. So in terms of our staff, our colleagues, our employee owners, we offer them the chance to use their own equipment. If they wish to use their own equipment, we will say to people, the deal is we'll provide you with a phone, a smartphone to tether or whatever else it will want to be, or you can use your own, and we'll pay you to use your own. Increasingly, people are using their own iPads or their own whatever else, and we actively encourage that, and we will support that through our help desk, and we're happy to support that through our help desk. In terms of in the community, we have partnered with now 4 local charities who exist to almost help support people become digital. In doing that, we have supplied quite a lot of kit to those people to enable that to happen. The big care homes, we have supplied tablets to. We'll be very happy to do so that essentially the first point of contact with a care home that anybody will have will be through Microsoft Link, so that the care home contacts somebody overnight, and district nurse, whoever, through Microsoft Link to enable that to happen. So we've had a completely mixed bag. I mean, you know, our deal with Dell means that we can pick a tablet up, as I'm sure many of the rest of you can, for south of £100. In the end, that's 2 appointments and you've saved your money. You know, so having major arguments about who owns what kit, we almost came to the conclusion wasn't worth the argument. To be honest, it's more about trying to get people onto the right place. Anything else? Because it says it's 20 past, Glenn, and I don't want to keep people away from anything else. Not at all. Thank you.